Very good afternoon and a very warm welcome to NITRD CTD NTF Difficult to Treat TB Clinic. On behalf of NITRD, it is my privilege to extend a heartfelt welcome to our additional DDG Sir, Dr. Sanjay Mattu, the directors and teams from NIRT and NTI, state TB officers, directors of STDC, faculty members from medical colleges, district TB officers, medical officers, and our team of case presenters and experts, and all the distinguished participants who have joined us, a very warm welcome. It is my privilege to welcome our national expert for the day, Padma awardee Dr. Rajendra Prasad sir. Sir, a very warm welcome to you. Today, our director had to leave for a meeting, so she will not be able to join. So I welcome Dr. Mattu sir. Sir, your presence is a great motivation for all of us. It also conveys your unwavering commitment towards care of DRTB patients. We look forward to your guidance. Over to Mattu sir.
Thank you, Singla ma'am. At the outset, I must congratulate and thanks all of the NITRD team, starting with Dr. Upasana Agarwal, who is the director of the institute. Then we are having this HOD of the department, chest department, Dr. Sanjay Gupta, Dr. Meena, and other team members who are there. Then we are having our esteemed national experts, Dr. Rajendra Prasad, Dr. Ashok Bhardwaj sir, NTF chair, and we are having a state representative from the case presenting team, state of Maharashtra, where we have the case presenter, state level experts, and the case experts are there from the Maharashtra, and eco team for the technical support. We all know that this difficult to treat TB clinic has been a platform where we are deliberating and discussing the most difficult cases. We all know that as per the, I hope I am audible.
Yes, sir, you're audible. Yes. Very clear, sir.
So we all know that as per our National TB Elimination Program guidelines, we are having very strict rule positions are there where we are following the DST based regimen. You understand that we are ruling out that
सर आपका म्यूट हो गया प्लीज अनम्यूट कर दीजिए
Okay, so I was just mentioning that as per our national TB elimination guidelines, we are having very strict rule positions are there where we are treating every individual with the TB cases as per their DST report so that their chances of failure or having higher success rate are better in such cases. But still, you know that after putting the person as per the DST reports, also we many times faces different challenges. And today's case is similar to that, where we have followed the DST based regimen. And in spite of having this DST based regimen, some of the DRTB cases are not responding clinically or bacteriologically, where we need to think out of the box and where we need to have this specialized support for the salvage regimen, where as per the clinical expertise of the institute and the system, we need to devise the regimen which is not mentioned in the books. We are having certain guidelines are there, which are the drugs which need to be replaced. But these guidelines also poses many times the challenges where we need the huge clinical experience is needed to design such a regimen. And after today's discussion, I hope that all the members who are there, we will be having the good discussion and all the doubts and the things will be clarified how we have to treat such cases which are most difficult to treat and are having the very unfavorable outcomes. Chances are more here in such cases. So today's case presentation will help out all the listeners and the participant so that they can also deal with such cases with ease and with better technical upgradation and the knowledge and skill set, so that the patient may be managed in better way and a better outcome can come forward with this particular in such particular scenarios. So all the best from my team. DDG wanted to join the meeting, but she was busy in other her priority areas where the MD's training session are being held. So she is busy in that, where mission director of all the states are being trained in the TB Mukt Bharat Abhiyan. So she conveyed that that message may be conveyed on her part, where she again wanted to thanks and congratulate all the team members who are there for this wonderful initiative which NITRD is taking up. And I hope that this support will be continued and we will be having more such cases for discussion. Thank you very much. Dr. Singla Madam may take it up further.
Yeah.
Thank you.
Thank you, Matu sir. Thanks a lot for your address. It really motivates all of us, to do better. The guidelines made by CTD are very, very helpful and very clear for everybody to understand. But there are always some cases which don't fit into those guidelines, and this clinic aims to help all such patients. So, thank you, sir. We would have moved to the case, but Dr. Bharadwaj sir, who is the chairperson for the National Task Force, has to leave for a meeting. So, sir would like to say 2 words to all of us before he leaves for the meeting.
So, thank you, Nita. Thank you. It has been almost 5 years for me to be associated with National Difficult to Treat Clinic. I feel this platform very informative, and except one meeting, I have attended all the meetings which were held when for the first time I joined this clinic as NTF chairperson. I have not missed but a single meeting. So in this meeting I also missing Dr. Rupak. He always sat on the right side of you, so we are missing him. So I but just want to say in supplement to Dr. Mattu, so we have to follow the guidelines which are being implemented by the program. I give one instance where I had to advocate, but I failed in the end stage. The person did not agree at all. He said that no, we will follow 4 month treatment regimen for DSTV regimen. So it was from my state only. It was a private hospital. I tried my level best, but he's always said he was pulmonary medicine specialist, worked in many positions. So he said that WHO is all over Government of India. So we will follow our WHO guidelines, but whatever Government of India say, we don't follow it, we follow. So there are some people, but we have to advocate our policies, our guidelines, so that they are followed, and the end result, we are for that TB patient. We have to see the management, the welfare of that TB patient, for whom right from the bottom to the top level of Vardhe Prime Minister, they are working for the welfare of TB patient. So I say best wishes to National TB Difficult to TB Clinic. So I will not be there next month or next to next month, but my all wishes will remain, and I always will be attending these difficult to treat clinics. So thank you very much, Dr. Nita, for giving me a chance for the last 4.5 years to be there, to be part of National Difficult to Treat Clinic. So thank you very much. Thank you.
Thank you, Bharadwaj sir. Sir, you completed your 100 clinics today, because last time we celebrated 100 clinics and you said you missed one clinic.
Yes,
So you
100th clinic.
completed.
So I hit a century today. Hit a century today.
Congratulations, sir. Thank you so much. So now we go ahead with our case presentation. And before I invite our presenter, let me introduce the faculty at the hub. I am Dr. Neeta Singla, and I am the nodal person for the DRTB Center at NITRD. On my right is Dr. Prapreet Sethi. She is a senior pulmonologist at NITRD. And on my left is Dr. Saroj Meena. She is also a senior pulmonologist in our institute. So with that, I invite the team for presentation. Today's team is from state of Maharashtra. Our case presentation is by Dr. Sharvari Rathod, who is a clinical associate in pulmonary medicine at Jupiter Hospital, Mumbai. Then our case expert is Dr. Praveen Tavre. He is from SMC GTB Hospital, Shivri, Mumbai. And state expert is Dr. Alpa Dalal, who is the head of the Department Pulmonary Medicine at Jupiter Hospital, Mumbai. And national expert for the day is Padma awardee, Dr. Rajendra Prasad sir, who is the Vice Chair National Task Force, and he is the Director Medical Education at ERA's Lucknow Medical College. So over to Dr. Sharvari for her presentation. You are muted, Dr. Sharvari.
Okay.
Yes. Good afternoon to the esteemed panelists, the state and the national experts, and all the audience who has come in today. Yes. So I would like to start my presentation today. I will share my screen. So today's topic is role of salvage regimen from cure to holistic rehabilitation. It will be a case of our patient for a journey of the last 10 years.
Neeta, may I come in?
Sure, sir.
Neeta, your voice is somehow vibrating. Some problem from my computer side?
Sir, it's from your side. यहाँ पे clear है, sir.
अच्छा, आपको clear है. Okay, go ahead. Maybe so.
Okay. So should I start my case?
Please, Dr. Sharvari, yeah, please.
Yes, please.
Yes. Okay. So a 25-year-old lady presented for the first time in our private sector OPD in 2023.
Dr. Sharvari, maybe आप अपना video stop कर दें because your voice is not clear. So maybe net is slow.
Dyspnea on exertion grade 2. There was no history of anorexia or loss. When she presented to us in December 2023, her weight was around 19. Oh, yes, sure.
Dr. Alpa,
yes. Hello. Yeah.
Yeah, Dr. Sharvari.
Net. Yes. Am I audible now, ma'am? Am I clear?
Right. Now you're clear. Yes.
Okay. I will just restart. A 25-year-old lady presented for the first time in our private OPD in December 2023 with the complaints of cough with scanty expectoration on and off since the last 1.5 years, dyspnea on exertion grade 2 since the last 1.5 years. There was no fever, anorexia, or weight loss. When she presented to us in December 2023, her weight was around 39.3 kgs. Saturations were 98%, maintaining on room air. She had a tachycardia of 122 beats per minute, and on respiratory examination, there were some bronchial breath sounds in the left supramammary area. So, looking back at her past history, there were multiple episodes of pulmonary TB that she had contracted. So, the first episode of TB was in 2015, where she was diagnosed to have drug-sensitive TB. However, the DST was not available. She had taken treatment in a private sector. At that time, from the records that were available with her, the regimen that was given to her was isoniazid, rifampicin, pyrazinamide, and ethambutol for a few months, and then she was shifted to some second-line drugs: moxifloxacin, linezolid, amoxiclav, clofazimine, and pyrazinamide. So this was the first episode in 2015. Later on, in February 2018, this was the second episode where she had a relapse of TB. This time she had received kanamycin, clarithromycin, clofazimine, linezolid, and cycloserine. In some records that were available with the patient, we found a DST that was done at Hinduja lab, that was of February 2018, which showed sensitivity to linezolid, kanamycin, amikacin, capreomycin, and clofazimine. And it was showing resistance to HRZE, streptomycin, ethionamide, PAS, ofloxacin, and moxifloxacin. So this was the second episode. Patient did not respond clinically, radiologically, and later also her AFB, sputum AFB culture came out to be positive towards the end of December 2018. This was the time when it was decided that the patient was initiated on bedaquiline. So a new regimen of drugs was given to her, which included bedaquiline, capreomycin, linezolid, clofazimine, moxifloxacin, and cycloserine. So this AKT she received for almost 20 months from December 2018, and it was stopped around in August 2020. So this was the third episode. So in the third episode, there was a relapse of symptoms around in December 2021. Here, her sputum AFB culture came out to be positive. Again, the patient was restarted on cycloserine, linezolid, moxifloxacin, and clofazimine. Here, a DST again from Hinduja lab was done. This was of January 2022, which showed sensitivity to bedaquiline, linezolid, amikacin, capreomycin, kanamycin, and clofazimine. So we have a few X-rays and the CT scan available of the same year in which there was a relapse of symptoms. This is of October 2021. So as we can see, is my screen visible?
Yeah, Dr. Sharjili, it's clear.
Yes. Yes. So this is of October 2021 when there was a relapse of symptoms. If I could go back, and this was the regimen that she was on. She was restarted on cycloserine, linezolid, moxi, and clofa. And this was the X-ray during that time. So as we can see, the X-ray and the CT scan, corresponding CT scan, it shows some inhomogeneous fibrotic kind of opacities in the bilateral upper lobes and few nodular opacities. Similarly, we can see on the X-ray also some right upper zone infiltrates, even left upper zone infiltrates are seen. So after this, in November 2022, she came to us in the public sector OPD at Shivdi TB Hospital. This is where, after a year, this X-ray was done. At this time, she was on this regimen: cycloserine, linezolid, moxifloxacin, and clofa. And this is an X-ray after 1 year. So we advised her a CT scan of the chest. However, patient was lost to follow-up after that, and she did not have much symptoms. So therefore, she did not come back to us and visit. So this was the last X-ray of November 2022 when she had visited to us in the public sector OPD. As she was doing symptomatically okay, she was lost to follow-up. So after that, we traced her back in April 2023. This is where she got a new job, and X-ray chest was done as a part of her pre-employment checkup, which was suggestive of active TB. So she consulted her general physician in a private sector again, and he had advised her a CT scan of the chest. This was the time in April 2023 where her weight was around 37 kgs. Here, the regimen that was advised to her was ethambutol 600 milligram, Pizina 1 gram, levofloxacin 500 milligram, and augmentin 375 milligrams. So this was given in her private sector. So this is the CT scan which was done in April 2023. Now, if we see this CT scan and compare it with the previous CT scan of this was the previous CT scan that was available of October 2021, where there were some inhomogeneous fibrotic opacities in the bilateral upper lobes and lower lobes. And if we see this CT scan after 2 years of April 2023, when there was a relapse of symptoms, we can see the left upper lobe cavitatory consolidations, a lot of nodular opacities in the bilateral lower lobes and centrilobular nodules as compared to the previous CT scan. So a large thick walled cavity is seen in the left upper lobe. So after 1 month of the ongoing treatment, patient had persistent cough and shortness of breath. However, there was a weight gain of 2 kgs. Here, a sputum gene export was done, which came out to be REFA resistant detected. And here, the regimen was again changed to AKT4 4 times a day. Linezolid 600 milligram was given and augmentin 375 milligrams twice a day. At this point, this is the point where this patient first presented to us in our private sector OPD in December 2023 with the complaints that I had mentioned in my first slide. She was having cough with this scanty expectorations intermittently since 1.5 years, dyspnea on exertion grade 2 since 1.5 years, and the vitals that was mentioned. So this was the first time that she presented to us, and the ongoing treatment that she was receiving was this. So at this point, we repeated her CT scan of the chest. Now, this is the CT scan of December 2023. The previous CT scan was of April 2023. And after for a period of 5 to 6 months later, this is her CT scan of December 2023. So we can see there was not much improvement in the CT scan that was done. So there is a persistence of the left upper lobe cavity, and upper bronchitic change and capacity are still persistent. And she was obviously having worsening of symptoms when she had presented in a private OPD. Now, after this CT scan, we had decided to do a bronchoscopy of the patient. So in December 2023, we did her bronchoscopy, and her BAL gene export was found to be MTB detected medium and REFA resistance detected. We did an export XDR on the same sample, which found to be resistant to isoniazid, fluoroquinolones, and ethionamide. And it was sensitive to the second line injectables. So at this point, my question to the experts is, what regimen should we give to this patient? And what are the patient's challenges? Am I audible?
Yeah, thank you, Dr. Shalvi. Very exhaustive history of the patient.
Yes.
So we'd like to open the forum for any questions that they may have regarding any investigations or any history of this patient.
Sure, ma'am.
Gita,
Yes, sir.
thank you for a nice presentation. I must compliment the PG who is presenting. And there are 2-3 questions comes to my mind at this stage. And as we can find that the weight was around 39 kg at every issue. One time it was recorded. Is there any family history of bad family history of tuberculosis in the family? Because I believe that she became ill at the age of around 15 years. Because presented 10 years, she has symptoms and undergoing very irrational type of a treatment. And then any bad family history there in the family?
No, sir. There was no history of any TB contact in the family.
And what was the education of the patient? What is the education?
Sir, she was, I think,
Is she literate?
she had done her 12th standard. She
12th.
was, yes, sir.
Okay. Okay. Go ahead.
Okay, sir.
Okay.
Do you have any immunodeficiency history, or have we evaluated her for immunodeficiency or anything?
Yes, sir, the viral markers and all the workup during the pre-treatment evaluation was done. So there was no any comorbid history or any immunodeficiency that was found.
Okay, and siblings were also healthy and they are okay.
She was the only child, so there were no
Okay,
siblings. She lives with her mother. Yeah,
okay,
and
noted.
yeah,
Thanks.
yes,
And the other question which comes to my mind,
yes, sir.
I believe that twice DST was done in Hinduja Hospital.
Yes, sir.
So it has shown that it was Mycobacterium tuberculosis or something other than Mycobacterium.
Sir, it was
Because
mycobacterium.
from a presentation, not clear.
Oh, yes, sir. Sir, it was
It was
mycobacterium tuberculosis only.
it was Mycobacterium tuberculosis.
Yes, sir. Yes, sir.
Okay.
Dr. Rathod, there are many questions in the chat box related to the history. May I ask them?
Yes, ma'am. Sure, ma'am.
So there's one question. Do we have a culture in smear report? The reports you have shown was the XDR plus and CVNet gene expert reports. So there's one question. Do we have a culture or smear positive till now? Or can these symptoms be explained by TB sequelae itself? Or does the patient also have some...
laptop है मेरा.
So, ma'am, we have the DSTs of January 2022, and this is of February 2018. So this
Okay.
was culture positive at around 6 weeks. Culture was positive, and on which this DST was run. So
Was the patient also symptomatic during this duration?
yes, ma'am, she was symptomatic. She had this intermittent cough, anti-expectorant, as I mentioned in my history. She used to be there. She used to get well. Again, she used to fall sick. So there was this continuous remission of symptoms that was happening throughout 2015 to 2023.
Dr. Darshan has raised his hand. Sir.
Yes, ma'am. Thank you, ma'am. Ma'am, actually, now the guidelines say you have to move towards a injectable-free regimen, but in this case, we should use injectables because this patient requires them, because it is kind of a last resort for this patient. So we should also include imipenem celastine in this patient, along with amoxiclav also, ma'am. So in this patient, we have to choose a regimen which is the best possible regimen for this patient.
So we are coming to that. It is
Hello?
also history part is being discussed. We are coming to the treatment part.
So sir, right now we are taking questions regarding history and diagnosis.
Okay, ma'am.
So one thing is very clear that when the patient was being treated so repeatedly with second line drugs, patient was never referred to government or to any DRTB center where he could have got a better opinion, because all the experiments were already done before patient reported to a DRTB center. So Dr. Praveen sir is the case management case expert for this case, who's been managing this case. So any comments from you, Dr.
Yes, ma'am. So she had visited to one of the DRTB center, which is UDTB center, and where she was already on 4 drugs, and she was symptomatically, like, she was having active symptoms, and that's why we have asked for HRCT, because on 8-9 months of treatment she was symptomatic, and that's why we asked for HRCT. But after that, she again lost her follow-up, and then again she presented to private setup. I think 1 year back, 1 year later.
So actually, she ended up taking treatment from private as well as public sector. So 2 times she received bedaquiline, and that was obviously available only in the public sector. So those 2 regimens she took from public sector, and then she has taken from private sector. So she's been, having mix and match. That's what it appears from the history.
Yeah, and also she has been repeatedly been on injectable drugs. especially
Yes.
Augmentin and then I think amoxiclav and other things. So where was she getting these injections from? And how was she taking it? Means, did you put any pick line or anything?
Yeah. So I think the second part we are coming to that about the treatment aspect.
Okay.
Can we go over if are there anything, Dr. Praveen, from your side about the case or any other questions on the history?
No, ma'am. So, looking
can we
at
move
the
on to
summary, yeah, we should go ahead with the
So
treatment.
yeah, so just to welcome Dr. Varinder Singh, who's a very senior TB specialist, pediatric TB specialist, and Dr. Yatin Dholakia. So I'd like to welcome both of them. Thank you for joining us. Yeah. Go to you, Dr. Alpa. Yeah. So do we move with the presentation? Ma'am, Dr. Varinder Singh have raised a few issues over the case. Was there any need of so many HRCTs in this patient? Like one was done in February or March and another was repeated in December itself. Dr. Praveen, can you answer this? Are we audible?
Yeah. Yes. So, yeah, symptomatically, she was not improving, and again, we didn't know her adherence to the treatment in between those 8 months, and we were planning to do her lavage because we didn't have any cultures, and that's why we have asked for HRCT. Though she has lost follow-up after that, and then again she presented in 2023, and then we did CT scan that time.
Is there any issue of compliance with the treatment during the previous episodes when she was in the privates and she was on the public and private hospitals in between? From the patient's end, was there issues of compliance, treatment compliance? How was the adherence?
Yes, ma'am. I would like to say, ma'am, the compliance was good. We had inquired in detail. However, the patient did lost to follow up, but as per the history given by the patient and her mother, she was compliant to the medications that were given to her in the public and the private sector of all the episodes that she was having before.
From the history, it also appears, I think, in between because when the advice investigations were not done. So some of the earlier episodes may be compliance may have been questionable also, and there was no consistency of care. The regimens are pretty irrational. So even if she had been compliant, I think those irrational regimens would have definitely not been effective.
True, ma'am. And therapeutic drug monitoring was never done for this patient.
What was the socioeconomic status of the patient? By the way?
Shalvari, I think patient must be from a good background because she's been in private sector throughout, so she could have afforded all the investigations and all.
Yes, ma'am. She was taking treatment from the private sector. So she came from I would say, a middle class socio-economic background. She was a single child. Her mother was a cook. But for the treatment part, she did visit to private OPDs also to take treatment. So I assume she was coming from a good socio-economic strata.
But I assume that after having spent so much of money, by the time she came to us for the last time, she had spent almost about 8-10 lakhs of rupees.
Yes, ma'am.
And Alpa, that is very disturbing thing in TB scenario in India. If somebody is spending about 8 to 10 lakhs before coming to these hospitals where drugs are freely available, that speaks about the condition, exactly what is happening in whatever we can see on the theory, but in practice, what do we see? This is not the first time I'm commenting, but the practices of the doctors are very poor, I must say.
Absolutely agree, sir.
has been very poor.
Yeah. So shall we, do we go ahead with your two questions that you asked, that what is the possible regime and what were the challenges? How did you deal with it?
Yes, ma'am. So should I move ahead, ma'am?
Yeah, please.
Yes. So after this, we tried to make a drugogram for the patient, and when she had presented to us in our hospital, Jupiter Hospital. So as per the drugogram, the drugs that were exposed and the recent DST that was showing resistance was to rifampicin, isoniazid, fluoroquinolones, and ethionamide. The drugs that were exposed before and the DST was not available was for the drugs. Yes, was for the drugs bedaquiline, linezolid, cycloserine, clofazimine, ethambutol, and pyrazinamide. The drugs that were not exposed and the recent DST was showing sensitive was amikacin. The drugs that were exposed before and the recent DST showing sensitivity was kanamycin and capreomycin. Drugs that were never taken before and the DST was not available was for the drugs delaminid, imipenem, and cilastatin. So as per this drugogram, we tried to formulate a new regimen for her. But before that, the dilemma that we were facing for this girl was all the different challenges that when she presented to us finally after having almost 4 episodes of TB in the past that were, as our experts mentioned, was bit of irrationally treated. The medical challenges, it was almost 10 to 11 years of chronic disease, extensive lung damage, highly resistant pre-XDR profile, exhausted her first and the second line AKT options, social challenges, as we just mentioned about the cost issue, pre-employment medical screening impacts, maintaining a new job while she was chronically ill, the stigma of the recurrent TB. She also faced a lot of psychological challenges, the mental toll of cyclical relapse of over this last 8 to 10 years, severe treatment fatigue and anxiety of navigating dual public and private healthcare systems, and of course the financial challenges. She was sustaining the cost of these second line drugs, private sector OPD consultations, and even the diagnostic costs. So, after doing the bronchoscopy and after getting the BAL reports in January 2024, we decided to do a PICC line insertion. So, PICC line insertion was done in private sector with the help of a private donor and self funding. And as per the drugogram that we had made, we decided to create a salvage regimen for her. And as per that, we decided to start her on bedaquiline, the intensive phase of 400 milligrams per day for the first 2 weeks, followed by 200 milligrams alternate day. Delaminid was added, 100 milligrams twice a day. Imipenem cilastatin injections were started, 2 grams intravenously twice a day, along with amoxiclav tablet twice a day, cycloserine 250 milligrams twice a day, amikacin 750 milligrams once a day, clofazimine 100 milligrams once a day, and linezolid 600 milligram once a day. So this is the regimen that we started her on 18th of January 2024. So she received injection amikacin and imipenem cilastatin from the national program only. And after 3 weeks of treatment, clinical improvement was seen. Her cough and shortness of breath had significantly decreased in the first 3 weeks of the treatment only. Her appetite improved, her food intake improved. After 3 weeks of treatment, the patient did develop some complaints of tinnitus. So we did her ENT workup immediately. But as per the audiogram, the ENT specialist advised us to continue amikacin. So we continued with amikacin. After around 2 months of treatment, we could see a weight gain of 5 kgs in her. Initially, when she had presented to us, there was a lot of tachycardia. Her baseline pulse used to be around 122 beats per minute. Now it had improved to 90 beats per minute. The BAL AFB culture came out to be positive. Then we ran a DST, phenotypic DST on her, which came out to be sensitive to linezolid, clofazimine, and moxifloxacin high dose. So as moxifloxacin was also sensitive in this DST, we decided to add moxifloxacin to her regimen. BDQ DST was not available. So this is in May 2024. So we started her treatment on 18th of January 2024. This is after 4 months of the Salvage regimen. She came to us for OPD follow-up. At that time, she did have some complaints of headache, some tingling sensations in the head and both the lower limbs. There was some decreased vision in the left eye, forgetfulness, some loose stool episodes that were happening intermittently. And after imipenem injection, she did have some nausea also. So we did a counseling of the patient on the OPD basis. We did her ophthal evaluation. We did her nerve conduction tests also. They were normal. So we decided to counsel the patient and continue with the regimen. So we did not have to stop cycloserine. However, later we did stop linezolid. I will mention that in the next slide. By this time, her sputum AFB culture, which was given before, had come out to be negative at the end of 6 weeks. This is the time when we did stop linezolid because of her persistent neuropathy symptoms. Loose stools and nausea, as I mentioned, it was managed with dietary changes and counseling. And we also tried to repeat audiometry every 2 months just to look for the evidence of phototoxicity. There was no evidence of phototoxicity. So we continued with the injection amikacin. We decided to give bedaquiline and delaminid for the entire duration of the Salvage regime. So that was extended for the entire duration. Imipenem, cilastatin, and amikacin injections the patient received for a total of 9 months. And towards the end of 9 months, there was a good weight gain of 9 kgs also. So we definitely could see a very good clinical response in her. There was good radiological response also and microbiological response, as I mentioned in the previous slide. It was no growth at 6 weeks of culture. Also, when we started her treatment, after 3 months only, the patient started doing her work from home. So her earning capacity also started after 3 months of the treatment. Her mother also left her job and tried to take care of the patient. She was very supportive for her. So she was also taking care of the patient at home. And she was looking after her nutrition very well. So that is what was very well appreciated by us also. So after 14 months of treatment, the entire Salvage regimen, we tried to repeat a CT scan of the chest just to look for the response. And I will show the CT scan in the next slide. And we decided to stop bedaquiline and delaminid. It was stopped on 1st of July 2025. That means after a period of almost 18 months of the Salvage regimen. And she had started, as I mentioned, after 3 months, she had started her work from home. After 9 months of treatment, when her sputum cultures were negative, she decided to go to her job. So she started her offline job after 9 months of her treatment. And moxifloxacin, clofazimine, and cycloserine, it was continued to complete 22 months of the total duration of the treatment. So bedaquiline and delaminid was received till 18 months, and the rest drugs, that is moxi, clofa, and cyclo, was given for a total duration of 22 months. So this is the last CT scan that we tried to do at the end of her treatment just to look for the response. And this is her pre-treatment CT scan, that is April 2023, when she first presented to us in our private OPD. And this is almost exactly after 2 years. So almost like 22 months of treatment. So as we can appreciate, the radiological response that is seen in the previous CT scan, all the left lower lobe cavitary consolidations and fibrotic changes have resolved much better in the recent CT scan of April 2025. Even the nodular opacities have gone down significantly. I hope the CT scan is appreciated. Is it visible clearly?
Yes.
Yes. Okay, sir. So finally, after 22 months of treatment, the ATT was stopped on 15th of November 2025. She completed 22 months, and after stopping her AKT, we followed her up after 6 months also in our OPD. She is clinically doing well. She just recently followed up in January 2026 this year. She's clinically doing very well. She's continuing with her job. She's supporting her family. She's enjoying her good quality of life. This is her follow-up X-ray of January 2026. That means we stopped her treatment on 15th of November 2025. This is after 2 months. This is her X-ray. And we can see there is a good resolution of the fibrotic opacities that were seen in all the previous X-rays when she had active TB. So the right upper zone, there were some fibrotic changes that have kind of gone. This is more of the post TOPD like X-ray, compensatory hyperinflation, and right upper lobe fibrotic opacities have gone down. So this was the last X-ray, the recent follow-up in the OPD. So with collaboration with the national program, private sector, private donors, patient's own efforts, and her family's continuous support, her 10 years of difficult journey ended positively. So right now I've come to the end of my presentation, and after going through the entire case, these are my questions to the experts and the panelists that are available. So I would like to ask if any alternative treatment regimen was possible for this patient. So these are my list of questions that I would like to ask, and I would like to open this for the discussion.
Yeah, so I think we let these questions be here so we all can have
Yes.
we can all have answers to these questions. And excellent presentation, Chervary. Very beautifully explained. Thank you so much. So now we open the forum for any questions. Dr. Darshan has raised his hand.
Ma'am, thank you, ma'am. So really, it was a very challenging case, and I just congratulate all the team for managing this case so beautifully, and finally, they have cured the patient, I must say. So now, ma'am, regarding the first question, I think they have tried all the possible drugs available, and so it was the best possible regimen for this patient. Regarding second, any other investigations, I should say that these patients, if they are having any symptoms, they should be investigated for CPA, chronic pulmonary aspergillosis, because most patient of post TB they develop chronic pulmonary aspergillosis. Of course, if the patient is not having any symptoms, then it is of no need. But otherwise, we should screen them for CPA. And regarding role of surgery, if the patient is symptomatically not, it is she or he is well, then of course no role of surgery is there. Otherwise, of course, we can, if patient is symptomatic, any hemoptysis kind of thing or anything else, uh, we can of course go for surgery also. And one more thing I want to like, because this is a national forum and you people are also well equipped. So, ma'am, it is my humble request to all of you, all dignitaries, that the program needs selective availability of WGS or NGS. Then we need therapeutic drug monitoring in a system and availability of drugs like PAS, imipenem, celestine. These drugs are not available in the program. So we have to. It is very hard for the patients to make them convinced to buy these drugs from outside. So sometimes, because we also are a, like COE at our center, and many patients who have failed MDR HDR, they come to us. So when we require these drugs, they are like patients are not affording those drugs, and sometimes we have to like manage uh, with whatever available resources we have. So these few points I wanted to bring to your notice. So if you people can escalate this request to higher forums and get these things available in the program, that would be like really a boon to all of us.
Thank you, Dr. Darshan. Dr. Mattu hopefully is listening to our discussion. So I think your thoughts are already shared, but we will also put in a word. We have more questions in chat. Any comments in the chat? Okay. So I have a question. Yeah. Ma'am, does the patient have any post-TB sequelae? I mean, symptomatic post-TB sequelae. As the X-ray, we can see there are changes of TOD, which you already mentioned. Is patient symptomatic for TOD?
Dr. Sarvari?
Yes, ma'am. So, yes, ma'am, the patient after follow-up when she visited us in January 2026, she does have some shortness of breath and after walking a certain distance, which she previously never had before in her previous episodes. There are some complaints. Sometimes she did also complain of some chest heaviness and chest tightness also. So we did advise her a complete PFT on the OPD basis, but somehow she couldn't do the PFT. So we used to check her peak expiratory flow rates. So in January 2026, her PFR value was around 260 liters per minute, which was less than her predicted value. So we decided to start her on inhalers also for the same. She's currently on inhalers and she is kind of managing those symptoms well now of shortness of breath. So she does have some OAD kind of symptoms also.
Thank you. Dr. Praveen, would you like to add anything to this case or discussion, anything that you would like to discuss?
Yes. So we'll do her PFT whenever she comes next time for follow-up. And
Yes.
as doctor already discussed about CPA, we'll have to again because she had in 2021 CT, she had one fungal ball which disappeared after that because cavity has collapsed now, which is now more fibrotic disease. But we'll have to again follow up her symptoms every 3 monthly. We'll have to call up her for follow up and see if she develops any symptoms in the form of hemoptysis, cough, breathlessness, and then we would like to evaluate further for possibility of chronic cavitatory or chronic fibrotary pulmonary aspergillosis. That is our plan. And if she develops again hemoptysis, then uh, we might have to see whether we need any bronchial artery embolization or not. She might have TB again. So again, we'll have to prevent first, and if we couldn't prevent, then we'll have to see why she's getting repeated infections, and for that we might have to evaluate her for immunodeficiency like CVID or anything with immunoglobulin panel and if required lymphocyte subset analysis.
Thank you, Dr. Praveen. Dr. Alpa, can we have your comments for this case?
Yes, so very well managed case and very well presented. So now this patient, when we go through the history, so of course that this girl was, I would say, very fortunate or lucky that we could end up with a positive outcome. But the pattern that we are seeing is that is really, really very concerning. So she has taken multiple episodes of treatment, almost 4 times, and fourth time the thing got right. Now, she was fortunate that her disease did not spread badly and it did not become bilateral. We see quite a few of such cases which are mismanaged with multiple episodes of irrational treatment, and we see that they get extensive lung damage and they get respiratory disability, and some of them lose life also. So I think from private sector and public sector, we have to really see that how these cases can be managed well in the first episode itself. I mean, she went through 10 years of treatment and ended up spending about 10 lakhs of rupees. And finally, after receiving the salvage regimen, she got treated. So, what we have to do from our public sectors, from our side, and what we have to do from the private sector, this is very important, and I think we should give a lot of thought to it. Apart from that, I would like to discuss about the case. So when she actually came to our OPD, in December 23. She had this long history of almost 8-9 years of treatment. And the challenges which were there. Now, there was no other alternative than giving her a salvage regimen, because all her other treatment options were kind of exhausted. And then we didn't want to give any other trial of inferior regimen. So when such patient comes to the OPD in the private sector, they cannot afford this expensive treatment. So imipenem cilastatin is yet not available at all the places in public sector, but we requested a NTP program in Thane, and the CTTB officer was very good, and the local purchase of imipenem cilastatin was done. And then the question of PICC line. So we managed to get some private donors, and PICC line was done in the private setup. And thing doesn't end here, because after getting the medicines also from the NTP program, they have to still manage to take the injection. So they have to pay to the nurse who comes to give the injection. They have to get weekly dressing done for the PICC line, and all this costs almost about 10 to 12,000 rupees a month. Okay? And that is a big challenge. So luckily we could manage to get all the drugs, amikacin and imipenem cilastatin, all from the program, and rest of the expenses were done by the patient. Also, it is important that when we are treating the patient with salvage regimen, it is very, very important that the side effects are managed well, because with the multiple drugs, they are going to have multiple challenges. Like this patient, she had a lot of headaches, she had tinnitus, and she had nausea, vomiting, psychological disturbance. And then we need to involve other specialists. So we had to involve an ENT specialist. We had to at some point take some psychiatrist's opinion. Counseling was to be done. And many times this becomes a challenge when we are managing the patient in the public sector, that under one roof, all the specialists may not be available at all the centers. Okay? But with all the multiple specialties involvement, these side effects could be managed well. And if we don't manage the side effects well, patient will either end up stop drugs, or we will stop some of the drugs, and again weakening the regimen. Okay, so that aspect is very important. Social challenges or financial challenges, like managing the drugs from the program, managing some private donors. Now all that had to go hand in hand. And mother family was also very supportive. So she left her job to look after this girl and to support her nutrition. So all these components were very important to get the result that we got. And now post-treatment vigilance is also equally important. So role of surgery, currently, yes, the surgery does not have a role, but as previously some of the experts have discussed, if she has any condition like acidosis, or she has any hemoptysis, then definitely the role of surgery would be important. And if she has any relapse, because sometimes these cavitary diseases are known to have relapse, and that is one of the reasons why she has had multiple relapse. And if she has any relapse, then I think we should definitely consider surgical option for her left upper lobe cavity. Okay. The next question is how to ensure implementation of guideline-based treatment. This is a real challenge. I do not have the answer to it. Maybe Dr. Mattu or some senior can have some suggestion on this. Can we really make private sector doctors accountable for the irrational regimen they write? It is actually very sad to see the kind of prescription that was being given. And like we had something in COVID where they had to comply with the guidelines. If they did not, I do not know. I'm asking on this forum whether we can have any, legal or any other way where we can, make this private sector physician accountable for what they write. Because this girl otherwise would have really lost her life, getting multiple. And last thing was availability of typical DST. So this again becomes a challenge at times in the public sector, that we don't have all the DST available upfront. Sometimes they're really delayed, and that also kind of weakens our our effort to give them a rational, treatment which is based on the data. So I think the message here is that we must manage our patients more aggressively with proper guidelines, proper medications, and with available DST, making all the efforts. Like in such a patient, when she was having multiple episodes, and somebody had asked the question why CT scan was repeated, because in span of 8 months the disease could become bilateral. In such a case, also had to decide if enough number of drugs are not there, maybe we might have to consider a surgical option. So for that, it was necessary to do a CT scan in span of 8 months and to see whether the disease has already become bilateral, and we have lost that option of surgical option, offering surgical treatment to the patient. So sometimes we really need to be aggressive. We need to have a holistic approach. We have to involve multiple specialty people. We have to have collaboration between the program and ultimately give results to our patients.
Yeah, thank you. Thank you, Dr. Alpa, for your expert comments. Over to our national expert for the day, Dr. Rajendra Prasad, sir, for his comment. Sir, आप muted हैं.
Thank you, Nita, for inviting me, and thank you, Dr. Alpa. You have beautifully analyzed the whole case. But I must say that the ordeal of this patient starting from 2015 to about 10 years ahead. And one thing I can realize, the education about tuberculosis is still very poor. I think Dr. Mattu must be listening. I have interacted with him many times. If this is the scenario in 2026, the management of tuberculosis, we have all guidelines, very well written, very well documented, very well propagated also. But still the education and the medical colleges somehow, I believe, is still poor, especially in tuberculosis. Now, you know that most of the companies has already stopped the education in tuberculosis. So government should take initiative so that education in that will help. My feeling and my thinking, education can change the whole world. Because you see in this lady, what type of, say unusual prescriptions were prescribed. And in the private sector, what we have seen, we have already read many papers from the Mumbai itself, how TB is treated in Mumbai. And probably education requires. And above all, if I see, I'm saying education, and the government, what they have removed the education, they have removed the Department of Respiratory Medicine, especially in those colleges who are imparting only undergraduate training. That is also not good. We are representing at every forum. When the education was there to the undergraduates, and when it will not, to proper education will not be there, it will be very difficult to manage such type of things. So that was the another point I would like to say about the role of surgery. As you know, she started lesion on the right side and then landed on to the left side, especially the cavitary lesion. And we know that cavity heals by two methods. One is closed method, another is open method. And in this lady, the cavity has healed by open method, as sputum culture is negative and everything. And this healing may, as many of you have touched, that this healing may create a lot of complications with tuberculosis. And it may have a recurrence in tuberculosis. So if effectively evaluated, and this upper lobe, I think left upper lobe is still having very thin wall cavity, And since her bacteria was also difficult, it appears that by 2-time DST, there was a lot of drug resistance. If although disease is bilateral, I agree that surgery is usually out of question. But if this left upper lobe can be dealt with, if the surgical opinion might be taken that the surgeon can dare to remove that lobe, so you will be removing that diseased portion. That will prevent further complications like somebody has already touched that CPA and recurrent hemoptysis he might have. So those things can be, but it is a difficult scenario. But a surgical opinion might be taken. Might a surgeon may, if possible, can take a daring. And another point was raised by the DSTs and more facilities. Although the government has increased the facility, but I also believe we need more and much more facility, which should be easily available. And another thing, what I am observing, what I've observed in last 50 years by now, the quality of these tests are also. I have seen many reports of very poor quality, differing reports from the different labs. That is another area probably which has to be tackled much faster. That whatever labs are there, they must be under quality. I think Dr. Mattu must be listening, and so that wherever person goes, person has a liberty to go at it. He gets the right sort of investigation, and then treatment point of view, education will improve the treatment practices, whatever bad we are having, that must. So if these things are tackled, probably next patient may not. And this is not the story of Mumbai. I can tell you in last 50 years, I have many such cases which are such ordeal. And because of the poor and irrational management, patient went on to develop drug resistance, multi-drug resistance, XDRT, and some of them are succumbing. I usually say that nobody should today in India die of tuberculosis. But WHO Global Report 2025 already has said that about more than 3 lakh people have died in India. So that is very unfortunate. That needs very definite, clear-cut education, persistent education, training and retraining, so that every doctor in our country, they get trained how TB should be diagnosed early and how TB should be treated properly. And if they cannot treat, please send to the government sector, because everything is free. It came very late in the government, I believe. So that is another issue we have to raise. Yes, if you are able to treat, if you are well trained, you can treat. If you are not trained, send to the government facilities where everything is available. So with this, I think I close my comments, and once again, thank you, Nita and the entire team for inviting me as a national expert.
Thank you.
Thank you very much.
Thank you, sir, for your comments. Now I request Dr. Prapreet Sethi if she has any comments to share with us.
At the outset, I would like to congratulate the team and Mumbai who had successfully treated the patient. A great applause for you all, because it was a really difficult case to manage. While we look at the case, we understand that the patient was given ineffective treatment over a long period, and majority was in the private sector. So the right concern would be, how do we involve the private sector to be, as Dr. Dalal has already said, accountable to whatever the regimen they are giving. Because we do have NTP in place, in case they do not, and for majority, 90% of the cases, the regimens which are mentioned in NTP are effective. Cases where, of course, you do not fit in, these patients do not fit into your NTP program, there's always an option of individualized treatment. For such cases, I would request that there should be a good collaboration between the private sector and the government sector where the patients are referred to the DRTB center at the earliest. The earlier we get patients, better is the outcome. There's no doubt about
तुम
it.
वार्ड में चलो, मैं
This
आता
is
हूँ
just
अभी।
place
चाय
where
मंगाइएगा
it
इसके लिए?
kind of improves the arrangement
ठीक है,
of
मैं
the
अभी राउंड
collaboration
लेता हूँ।
between the private sector and the government sector. One of the issues is this. Now, when we look at the history of the patient, when the patient has taken almost 2 years of treatment in December 2022, when the patient had come in, she was still culture positive. That means that the patient had failed on whatever treatment she was given, and the patient was given a treatment containing bedaquiline regimen. So, ideally, if the patient has taken the treatment regularly and still failed, there are certain concerns which you should, when the patient reports to you, you should be aware that what are the causes, rule out the causes of failure. Why has the patient failed on a regimen which you think is according to your DST and has given a good regimen, bedaquiline containing regimen. So you need to rule out whether the patient is taking the treatment regularly or if the doses which is given by to the patient is according to the weight band. So that is also essential. The patient may be taking all the medicines regularly and the right dose or regimen, but the doses are not good enough. So then it would be ineffective. And so these are another one very important is the malabsorption syndromes. These need to be ruled out whenever you get the case of failure. Now we do have therapeutic drug monitoring to help us in these cases. In NITRD, we have already developed the first line and second line also we are doing certain drugs which will definitely help us to monitor such cases for failures. Okay, so therapeutic drug monitoring is one of the options which you can assess during this time. Now, when the patient has come after failure, now you need to also understand was the patient taken the even after taking what was the culture and smear and follow up. We do not have any reports in the follow up. So if the patient is under anyone's treatment for 2 years, we need to have some follow up, maybe smear, maybe culture, ideally a culture. But if we do not have that, then you need to assess and we need to tell our treating physicians that this is an essential because unless we do our smears and cultures right on time, we are not going to catch our failures at the earliest. Our purpose is to catch the failure at the earlier, not after completing 2 years of treatment. There's no point in doing it because after giving a failed regimen for 2 years, not only the patient is suffering, you are losing out on other drugs which you could have saved. So that is one of the essential where you need to see the follow-up also, whether you are getting the smears done, you are getting the cultures done. Now, once the patient has come to me for treatment, what you need to assess is the culture sensitivity. What are the drugs which you can offer to this patient? As Dr. Dalal had very, very properly mentioned the drugogram, which is very essential because whenever you are formulating a regimen for DRTB, these patients will not fit into your conventional NTEP program regimens. You need to think beyond those. So, how do you make a regimen for these cases? Ideally, your IP should contain at least 4 to 5 drugs which are sensitive, that is document sensitivity, or likely to be sensitive. That means probably the patient has not taken those medicines earlier. And the CP should have at least 3 to 4 drugs. So whenever you're making a regimen, and in this case, they have done it very beautifully, where they encompass all the drugs which were there available for them and extended where required. So bedaquiline and delaminid was continued for an extended period, which really helped the program for the patient to recover from the disease. So there was an excellent part on the treating physician on that aspect. So when you are, and the use of extended DST, not just we need to have the availability of extended DST, the other drugs, because this patient has taken almost every drug before coming to the treating physician. So you need to have your DST, extended DST that will help you to form an effective regimen, as was done in this case. Again, this case was managed very beautifully. Follow-up was a problem we must have done. We do not have the reports of cultures and all, but since the patient has recovered, we assume that it was done regularly. One aspect which really catches our eye in this case is the toxicity of linezolid, that is peripheral neuropathy and loss of diminution in eye eyesight. So in such cases, wherever in follow-up, when this patient ideally on MDR treatment should come to you or follow-up every month. So when the patient comes to you every month, there are certain questions which you need to do. So for peripheral neuropathy, you could ask about the tingling numbness. These are the leading questions which you need to ask. This is compulsory. So whoever is the treating physician or your technicians who are giving the medicines should be trained in these aspects, where what are the leading questions that they need to ask. And in the OPD, we do have Ishihara charts. This should be kept with everyone, because that is the earliest the color vision which goes with linezolid. So everyone, whenever a patient complains, visual acuity and color chart, Ishihara chart, these are the two things you need to have with you, and that can catch the patient's complaints before permanent damage is done to these cases. So these, before you have the chance to refer, as ma'am said, not every center has a specialist. It could be a ENT surgeon or an ophthalmologist. So in these cases, minimum small things like a visual acuity and an Ishihara chart definitely helps you to catch hold of the initial changes or the initial complaints. And anyone who has these complaints should be referred, because these are kind of, if it's a possibility that the patient would lose the eyesight. So that is really very sad. Though you may save the life, but if you increase the morbidity, it really hurts the patient. So that is why you need to take care of these side effects in such cases where you're giving an extended treatment. And as for the surgery, it's my personal opinion that this patient should be given an option of surgery at this stage also, because as it is, we do not have many drugs left in case this patient relapses. So this is if her PFT is good, because though it is a bilateral disease, predominantly the cavitary disease is on one side, the other is just fibrotic. So the cavity, if removed, would reduce the chance of relapse, and as already was a documented case of aspergilloma, that also reduces the chance of redevelopment of aspergilloma and other symptoms there. So surgery can be offered if the patient is fit on PFT. In case that is not, the least which we can do is pulmonary rehabilitation. Essential now for all post-TB patients. Pulmonary rehab is great way, and it's coming up. Every patient should be offered and assessed for the need of pulmonary rehabilitation, because very simple, just respiratory breathing exercises and all these would help the patient lead a very normal life. So there are few very small things: regular follow-up, every 6 monthly follow-up with a sputum, with culture, with urine X-ray, and pulmonary rehab should help this patient lead a very, very normal life. And just my concern is over dependence of private sector in towards radiological. That's my personal opinion. Again, they're rather than getting an HRCT or a CT scan or whatever, it is better, because there are certain changes which were evident on the X-ray also. The cavity development on the left side was evident in the X-ray in December 22 as well. So these are certain things where your clinical acumen really helps you, and a regular follow-up would definitely help these patients to lead a normal life here on. And once before I finish my thing, I would again congratulate the team for doing an excellent job and survival of this patient. Thank you so much. Thanks a lot.
Thank you, Dr. Sethi. So at the end, if anybody has any comments or anything that they would like to add, can we stop the screen share, please? I hope all these questions have been answered, and we are better equipped to answer these questions now. So I would just like to mention some take-home messages for the people who are in the field, for our DTOs, for district TB officers, that we should identify the non-responders at the earliest and refer.
Nita, before you end up, just allow me to.
Yes, sir.
I must compliment Dr. Sethi for very analyzing very well and all the suggestions. And second thing, this is the first, I think, NITRD difficult to treat TB clinic, where we are missing the, you know about whom I am talking. डॉक्टर साहब कहाँ चले गए भाई? उनको तो आप स्पेशल इनविटेशन देना चाहिए कभी कभी, मैं कहूँ.
Sure, sir. I'll pass on your message.
क्यों नीता सिंगला है?
Bilkul, sir.
Sometimes you call him as a special invitee also, right?
Sure, sir.
He has been very useful for this difficult to treat TB clinic. So although you people are there, I don't have, but sometimes I think it will be good if you call him as a guest something.
सर पद्मश्री की फिर से बधाई हो सर. पद्मश्री की सर बहुत बहुत बधाई हो फिर से सर.
Thank you.
पद्मश्री की सर फिर से बधाई हो सर.
Thank you.
Thank you, sir.
Thank you, everyone.
Yeah, so we would like to wind up our clinic and just give some small take-home messages that we should identify non-responders and not say failures, but non-responders at the onset before they become failures and refer them to higher center. But before referring the patient to higher center, please do the culture in DST because many patients come to us at NITRD and the DRTB committee has to wait for almost 1.5 to 2 months to get the culture and DST report. So when you are referring the patient, if we already have a report, it becomes much easier for DRTB committee to decide on to the medicines which need to be given. Also, at the field level, we should be thinking of if the patient is already on second line, the adverse drug reactions, and then contact tracing in the family. So that is also very important that we do the contact tracing at the earliest and put those also on treatment. Then training and sensitization of private sector within our district. That's our responsibility as DTOs to do sensitization sessions for them. We are being provided fund also for that. We have a PPM coordinator. So we should try to make use of them and try to sensitize our private sector as much. And I would definitely agree with Dr. Darshan Bajaj regarding availability of WGS or NTGS, therapeutic drug monitoring, PIC line, and imipinam injections and other drugs which are not available under the program. So those are something that the DRTB centers need to have to, make a regime and provide a regime to the patients. So with this, I thank all my experts and presenters for making it a very interesting session. Thanks a lot, Dr. Sethi, Dr. Saroj Meena, Dr. Alka, Dr. Praveen, Dr. Sharvari, and Dr. Rajendra Prasad sir for supporting this clinic and make it very successful. Thank you so much.
Thank you, ma'am.